Alterations of musculoskeletal function in children. Clubfoot, medically known as Talipes Equinovarus, is a condition where the foot turns inward and downward. It can be positional, idiopathic, or teratologic, depending on the cause. This congenital deformity affects the structure and function of the foot. Treatment typically begins early and involves serial casting, often using the Ponseti method. This image shows a classic presentation of clubfoot. Left untreated, the condition can cause permanent disability. However, early casting and corrective methods have a high success rate. Surgery is reserved for cases that don't respond to conservative care. Developmental dysplasia of the hip, or DDH, refers to abnormal development of the hip joint, involving the femur, acetabulum, or both. It may be idiopathic or teratologic, occurring secondary to another disorder. Risk factors include female sex, breech position, oligohydramnios, and family history. Early detection improves outcomes significantly. DDH can present as subluxation, dislocation, or acetabular dysplasia. Clinical signs include asymmetric skin folds, Galeazzi sign, and limited hip abduction. The Ortolani and Barlow maneuvers are used to detect hip instability in newborns. These signs help identify the condition in its early stages. Management includes the use of a Pavlik harness to maintain proper hip alignment in infants. If this fails, a closed reduction with spica casting may be necessary. In older children, surgical correction may be required. The earlier the diagnosis, the better the prognosis for normal hip development. This image illustrates normal versus dislocated hips. As children age, untreated DD can lead to limping, hip pain, and early arthritis. Regular screening during infancy helps ensure early intervention. Long-term outcomes depend heavily on the timing and success of treatment. Osteogenesis imperfecta, or brittle bone disease, is a collagen-related genetic disorder that weakens bones. It affects both bone and vascular collagen, making bones prone to fractures. There are several types based on severity, with types I and IV being mild and types II and III more severe. The condition follows autosomal dominant or recessive inheritance patterns. Children with this disorder may show osteopenia, frequent fractures, and bone deformities like bowing. Type 3 cases often feature short stature, blue sclera, and poor dentition. Serious complications include aortic aneurysms. Diagnosis is clinical and often confirmed through genetic testing. Management includes surgical placement of rods to stabilize long bones and prevent deformity. Calcium and vitamin D support bone health, while bisphosphonates can help reduce fracture risk. Physical therapy improves mobility. A multidisciplinary approach enhances quality of life. This slide shows radiographic examples of fragile bones in children with OI. Long bones may appear bowed, with multiple healed fractures. Close monitoring and early orthopedic intervention are essential. With proper care, many children can lead active lives. Osteomyelitis in children is often caused by bacterial infection, typically beginning as an abscess in the metaphysis of long bones. The infection can rupture through the periosteum, spreading into the marrow and along the bone shaft. This leads to the formation of a bony covering called an involucrum. Prompt recognition is essential to avoid long-term damage. Clinical signs include localized pain, swelling, warmth, and fever. Blood tests often show elevated white blood cells, C-reactive protein, and sedimentation rate. Treatment includes long-term antibiotics, typically for 6 weeks, and in some cases, surgical debridement to remove infected tissue. Early treatment improves prognosis. This image highlights the spread of infection through bone and soft tissue. Imaging and cultures help confirm the diagnosis. Management should be aggressive to prevent chronic osteomyelitis. In severe cases, surgical drainage may be required to relieve pressure and prevent necrosis. Septic arthritis is a joint infection caused by bacteria or granulomatous organisms. It may occur on its own or as a complication of osteomyelitis. Bacteria release enzymes and toxins that destroy articular cartilage and cut off the joint's blood supply. This is a surgical emergency that requires prompt treatment. Symptoms include pseudoparalysis, where the child refuses to move the affected limb, guarding, and inability to bear weight. Systemic symptoms include fever, anorexia, and general malaise. The infection progresses quickly and can cause permanent joint damage. Early recognition is critical to preserve joint integrity. The most common organism is Staphylococcus aureus. Treatment involves surgical debridement and 2 to 3 weeks of antibiotics. Ongoing monitoring is needed to assess for joint damage or recurrence. Long-term follow-up ensures proper joint development and function. Juvenile Idiopathic Arthritis, or JIA, is a childhood form of autoimmune joint inflammation. There are 3 major types: oligoarthritis, affecting fewer than 5 joints; polyarthritis, affecting 5 or more; and Still's disease, a systemic form with fever and rash. JIA is the most common chronic rheumatic disease in children. Unlike adult rheumatoid arthritis, JIA often affects large joints and has low levels of rheumatoid factor. Complications may include uveitis, subluxation, and cervical spine fusion. Treatment includes anti-inflammatory drugs, methotrexate, and sometimes biologics. The condition can affect growth and lead to long-term joint damage if not managed early. Osteochondrosis refers to a group of disorders caused by insufficient blood supply to growing bones, particularly at stress points. Contributing factors include trauma, clotting abnormalities, or genetic predisposition. The result is bone necrosis, often followed by regeneration. These conditions can cause joint pain and limited motion during growth. Legg-Calvé-Perthes disease involves temporary loss of blood supply to the femoral head, leading to a vascular necrosis. It is a self-limiting disease, more common in boys, and typically affects children ages 4 to 8. The cause is often unknown, but trauma precedes onset in nearly half of cases. Symptoms include hip pain worsened by activity and relieved with rest. Children with Legg-Calvé-Perthes may present with hip stiffness, a limping gait, and limited internal rotation or abduction of the hip. A common finding is spasm on hip rotation. A Trendelenburg gait may also be observed, caused by weakness in the hip stabilizing muscles. Early detection is key to preserving joint structure and function. Management includes anti-inflammatory medications, activity modification, and physical therapy. Serial radiographs monitor disease progression. In some cases, surgical containment may be needed to ensure proper healing of the femoral head. The disease typically resolves over time, but outcomes vary depending on age and severity. This image shows the stages of femoral head necrosis, fragmentation, and healing. Long-term consequences may include hip deformity, early onset arthritis, and reduced mobility. Early intervention offers the best chance for a smooth, spherical joint surface and normal hip function into adulthood. Osgood-Schlatter disease is a painful overuse injury of the patellar tendon at the tibial tubercle. It typically affects physically active children, especially those involved in jumping sports. Symptoms include anterior knee pain, swelling, and tenderness over the tibial bone. Treatment involves rest, activity modification, and sometimes immobilization for 4 to 8 weeks. Scoliosis is a rotational curvature of the spine. It can be non-structural postural or temporary or structural, involving fixed spinal deformity. Idiopathic scoliosis is the most common form, especially in adolescent girls. Bracing may prevent progression, while severe curves may require surgery. This image shows varying degrees of spinal curvature. When curves exceed 30 degrees, girls are more likely to be affected. Severe scoliosis can impair lung function, posture, and appearance. Early screening during growth spurts helps ensure timely intervention. Neuromuscular disorders are inherited conditions that cause progressive muscle weakness and wasting. They affect not only movement, but also respiratory and cardiac function. Early diagnosis through genetic testing is becoming more common. Management requires lifelong support from neurology, orthopedics, and rehabilitation teams. Duchenne muscular dystrophy, or DMD, is the most common neuromuscular disorder in children. It's X-linked, primarily affecting boys. DMD results from mutations in the dystrophin gene, leading to absence of the protein that stabilizes muscle fibers. Muscle cells break down over time, causing weakness and degeneration. Symptoms usually appear by ages 3 to 4 and include delayed walking, frequent falls, and difficulty standing. A hallmark sign is the Gower maneuver, where children use their hands to push up from the floor. The calves may appear enlarged, but are actually weak due to fatty infiltration. As the disease progresses, most children lose the ability to walk by age 12 to 13. Complications include respiratory failure, cardiomyopathy, and scoliosis. Cognitive difficulties and gastrointestinal issues may also occur. Management requires a multidisciplinary approach including physical therapy, corticosteroids, and respiratory support. Spinal muscular atrophy, or SMA, is an autosomal recessive disorder that causes progressive degeneration of motor neurons in the spinal cord. This leads to muscle wasting, weakness, and loss of movement. Clinical signs include tongue fasciculations, a bell-shaped chest, and tremors with quadriceps atrophy. Treatment is supportive and may include respiratory care, feeding support, and genetic counseling. This condition is a genetically inherited, autosomal dominant disorder that causes progressive weakness beginning in the face, shoulder blades, and upper arms. It is typically diagnosed in late childhood and progresses slowly. Scapular weaning is a hallmark sign. Pain is common, and treatment may include NSAIDs, bracing, and physical therapy. Myotonic dystrophy, or MD, comes in two types: Type 1 DMPK Jun and Type 2 CNBP Jun. It presents with muscle stiffness, known as myotonia, along with distal muscle weakness, learning disabilities, or intellectual impairment. It is a multi-system disease, often involving cardiac, endocrine, and cognitive symptoms. Diagnosis is confirmed by genetic testing. Benign bone tumors in children are common and often discovered incidentally. Osteochondromas may be single or part of a hereditary syndrome and appear as bony protrusions. Non-ossifying fibromas are well-defined lesions seen on imaging and occur in nearly 30% of children. These are usually painless and managed with observation. Osteosarcoma is the most common malignant bone tumor in childhood, typically developing during growth spurts. It originates from mesenchymal cells and often involves the metaphysis of long bones, especially around the knee. Genetic mutations on chromosome 13 and the SRC oncogene are associated. The tumor often presents as a large, painful mass. Children with osteosarcoma often report night pain, swelling, and warmth over the affected area. If the tumor metastasizes to the lungs, symptoms like cough and chest pain may occur. Treatment involves chemotherapy and surgical resection. Prognosis depends on the stage and response to treatment. Ewing sarcoma is the most lethal bone tumor in children and often forms a soft tissue mass outside the bone. It can rapidly metastasize to organs like the lungs and liver. The tumor penetrates the bone and may be mistaken for infection or trauma initially. Prompt diagnosis and aggressive treatment are critical. Symptoms of Ewing sarcoma include intense pain, fever, fatigue, and anorexia. Imaging often shows a moth-eaten bone appearance. Treatment includes radiation, chemotherapy, and surgical removal. Long-term follow-up is required due to high recurrence risk. Certain fracture patterns in children raise concern for non-accidental trauma or child abuse. Corner fractures and transverse tibial fractures are common red flags. Multiple fractures at different healing stages may be seen. However, conditions like Osteogenesis Imperfecta must be ruled out. Early involvement of child protection services is essential when abuse is suspected.